Imagine waking up tomorrow to find that over 1,700 health clinics around the world have suddenly locked their doors. Imagine discovering that in just 1 year, over 77,000 kids have unexpectedly lost access to life-saving treatment. Well, this isn't some hypothetical scenario for the distant future. These are the massive, real-world numbers defining the 2025 global health crisis. Welcome to this explainer. Today, we're taking a structured, data-driven look at the current global health funding freeze. We'll explore what it means for the medical infrastructure keeping millions alive, and specifically, what this all means for the future of Nigeria.
To really understand the scale of this crisis, we have to start with a number that's honestly pretty staggering. $3.1 billion. For the 2025 fiscal year, the United States Congress appropriated $6 billion for PEPFAR. That's the President's Emergency Plan for AIDS Relief. However, the executive branch only made $2.9 billion of that available. The rest was just left unallocated. That creates a massive multi-billion-dollar gap in funding, and it's sending absolute shockwaves through the global health system. Okay, let's dive into this. Here is our roadmap for today's explainer, going from the global view right down to Nigeria's specific vulnerabilities. First, the 2025 global crisis. Second, Nigeria's HIV infrastructure. Third, the spillover effect. Fourth, the 2014 warning sign. And finally, what's at stake for 2026? Let's start with Section 1, the 2025 global crisis. So what is the immediate, on-the-ground fallout of this funding freeze globally? Well, the numbers from the recent PEPFAR pulse study are pretty stark. Because of terminated or delayed payments, 1,714 HIV service sites have permanently closed globally. We're talking about 1,010 public health facilities just shutting their doors. We are seeing a 14.2% drop in children receiving treatment, that's over 77,000 kids, and a devastating 51% drop in prevention spending. The absolutely crucial point here is that these aren't just paused services. This represents the physical loss of infrastructure, severed supply chains, and the laying off of highly trained medical personnel. Moving right along to Section 2, Nigeria's HIV infrastructure. Now, Nigeria carries the third largest HIV burden in the entire world, making it a really critical place to see how these global cuts play out locally. And the data reveals a profound dependency. PEPFAR isn't just a casual contributor to Nigeria's health system, it's the absolute backbone. After investing over $6 billion across 2 decades, PEPFAR covers an astounding 90% of Nigeria's HIV treatment needs. Only 10% comes from other sources. When you have a health system this reliant on a single international source, any disruption is fundamentally catastrophic. And this brilliantly illustrates what that money actually built over the years. Between 2004 and 2011, labs supported by Harvard and the AIDS Prevention Initiative in Nigeria, or APIN, delivered over 2.5 million tests. This covered everything from viral load monitoring to infant diagnoses. PEPFAR didn't just drop off boxes of medicine, they built a massive permanent clinical footprint that completely transformed the scale of diagnostic medicine in the country. Let's look at how this builds into physical reality. At the Jos and Lagos University teaching hospitals, this funding meant the construction of dedicated advanced molecular testing labs, known as PCR rooms. It paid for clean rooms for reagent preparation, uninterrupted power supplies with heavy-duty backup generators, and strictly controlled physical environments to prevent contamination. This is permanent physical healthcare infrastructure that was built and sustained by these funds. Which brings us to Section 3, the spillover effect. Once you build that kind of permanent infrastructure, something fascinating happens. Think of it like a giant iceberg, where HIV treatment is just the visible tip above the water. Researchers call this the spillover effect. It's defined as what happens when investments targeting one specific disease inadvertently strengthen other completely unrelated areas of the health system. In Nigeria, because PEPFAR built these incredibly robust labs, trained so many healthcare workers, and established such reliable supply chains for HIV, it had a massive knock-on effect. It actually improved maternal survival rates, boosted child health, and elevated the general medical capacity for patients who didn't even have HIV. The whole system leveled up.
All right, Section 4, the 2014 warning sign. So what happens to that entire interconnected system when the funding is suddenly pulled? Well, we have a very clear historical precedent from 2014 to show us exactly what happens. Back in the early 2000s, PEPFAR was essentially an emergency response. By 2008, they transitioned to PEPFAR 2.0, which focused heavily on country ownership, basically the idea that local governments should take over the funding. As a direct result of this policy shift, in October 2014, comprehensive HIV clinics in the APIN network in Nigeria faced a sudden, localized 60% budget cut. The results were immediate and mathematically brutal. Comparing pre- and post-cut capacities, viral load testing plummeted from 92% down to 64%. Project staff employment crashed from 80% to just 20%. Defaulter tracking, which is how clinics find patients who miss their medication, dropped from 100% to 44%. Prevention services absolutely tanked, falling from 84% to a mere 16%. There is a direct, undeniable link here between funding levels and the quality of human care. Now, what's really interesting about this slide is how it perfectly maps out the anatomy of a health system collapse, a catastrophic domino effect. It starts with a funding drop. That leads immediately to database maintenance failing, lab interruptions, and reduced wages. In turn, clinicians are forced to treat patients with incomplete data, and providers work unpaid hours, which completely destroys morale. Ultimately, these cascading failures lead to one outcome. Patients wait longer, they refuse services, and finally, they just drop out of care entirely. So how did these clinics even survive this 2014 cut? The answer is they passed the cost to the patients. 96% of the clinics surveyed had to introduce out-of-pocket user fees just to keep the lights on and the labs running. The median fee was $40 a year. In a country battling severe inflation and economic challenges, a $40 out-of-pocket fee fundamentally changes who can access life-saving care, creating massive barriers for the most vulnerable.
Finally, Section 5, what's at stake for 2026?
We need to take what we learned from 2014 and bring it right back to the present day. We have to contrast these two events because the scale is entirely different now. In 2014, it was a localized warning, a 60% cut to specific clinic networks that managed to scrape by using user fees. Today, in 2025 and 2026, we're looking at a multi-billion-dollar global freeze. $3.1 billion sits unallocated. As a result, 1,714 sites haven't just reduced their staff, they have permanently closed. Regardless of the political mechanics in Washington that led to this freeze, the operational reality on the ground is that this is an infrastructure wipeout on a massive scale.
And the projections are absolutely terrifying. According to a modeling study published in The Lancet, fully discontinuing this funding could generate 10.75 million new HIV infections and 2.93 million additional deaths globally. The authors literally compared this potential toll to a major armed conflict or a global pandemic. And we have to remember, if funding is restored tomorrow, it doesn't instantly fix the problem. You can't just flip a switch to reestablish severed supply chains or immediately rehire thousands of laid-off, highly specialized healthcare workers who have moved on to other jobs. Looking specifically at the African continent, infectious disease experts are forecasting up to 74,000 excess HIV deaths by the year 2030 strictly as a result of this funding policy shift. To put that into perspective, these are entirely preventable deaths, driven entirely by the sudden dismantling of an integrated, highly functional health network. Which leaves us with this final, critical question. We've seen the data. If a localized cut in 2014 was enough to cripple clinics and tank care quality, what happens to Nigeria's fragile, deeply interconnected health system when half of the global HIV budget simply vanishes? We are watching a slow-motion stress test of Nigeria's medical resilience with millions of lives hanging in the balance. Thank you so much for joining me for this explainer. Keep learning, and I'll see you next time.